morning everyone. The presenting paper is Clinical Profile of Atypical Optic Neuritis in a series of 3 cases. Presenting author myself, Dr. ARAVINDH BABU, GGH Guntur. Introduction: Optic neuritis is an inflammatory demyelinating optic neuropathy causing acute uniocular binocular loss of vision. The diagnosis is mainly based on clinical history and examination findings. Investigations like MRI, lumbar puncture, and antibodies against aquaporin P4 and myelin oligodendrocyte glycoprotein help in finding the association and cause of vision loss. Once the diagnosis is established, the treatment is done based on optic neuritis treatment trial protocol. First case: 34-year-old female presented with chief complaint of diminution of vision in both eyes, left eye greater than right eye, since 3 months, which is gradual progressive nature, as not associated with headache. No other symptoms like fever, vomiting, seizure, or any other systemic illness. On examination, best corrected visual acuity in right eye 6/12, left eye 6/36. Color vision normal in right eye, left eye identifying only primary colors. Anterior segment normal in both eyes, pupil normal in right eye, RAPD grade 2 present in left eye. Lens were clear in both eyes. Fundus examination, both eyes pale optic disc with a distinct margin, and CDR 0.6:1 was noted. Normal vessels and FR present. This is the fundus image. You can see the pale optic disc in both eyes. MRI bench showed evidence of tortuous course of bilateral prechiasmatic segments of optic nerve, suggesting bilateral atrophic optic neuritis with anti-MOG antibody positive and anti-aquaporin P4 antibody negative. Automated visual field was done in right eye. Non-specific scattered depressions noted in pattern deviation plot. Near normal fields noted on repeat fields on left eye due to learning curve. This is the visual field. The patient was admitted in neurology ward and got treatment with IV pulse method prednisolone 1 gram for 3 days, followed by oral prednisolone 60 mg OD. Injection rituximab were also administered. No visual improvement was noted following treatment. Case 2: 22-year-old male patient referred from neurology ward with history of painful loss of vision in both eyes since 1 month, which is gradual and progressive in nature, who is a known case of psychiatric disorder and seizure disorder. History of chronic alcohol consumption and smoking habit was there. No other symptoms. On examination, best corrected visual acuity was perception of light positive in both eyes. Anterior segment was normal in both eyes. Pupil mid dilated sluggish in reacting in both eyes. Lens was clear. Fundus examination in both eyes, disc edema with blurring of margin associated with disc failure in initial condition with associated with macular folds. Contrast enhanced MRI brain with both orbits showed demyelinating or encephalitis. Contrast enhanced MRI whole spine showed non-enhancing subtle T2 hyperintense areas in spinal cord from D8 to D11, probably demyelination. Anti-MOG antibody positive and anti-aquaporin 4 antibody negative. Patient was also admitted in neurology ward and same treatment as followed. Vision improvement to hand movement was noted. This is a fundus image. Pardon me for the non-clarity of the image. You can see the optic disc pallor in both eyes, which is taken after 3 weeks of presentation. Case 3: 50-year-old female patient referred from neurology ward with history of loss of vision in both eye since 15 days, which is also gradual progressive associated with retrobulbar pain. History of cataract surgery done right eye before 1 year. No other symptoms. On examination, best corrected visual acuity is also PL positive in both eyes. Anterior segment normal in both eyes. Pupil sluggishly reacting to light in both eyes. Right eye lens pseudophakia, left eye grayish white opacification was noted. On fundus examination, right eye mild disc edema with a distinct margin associated with temporal paleness in left eye hazily seen. B scan was done, right eye anechoic and left eye vitreous echogenicity present. This is the fundus image showing in right eye temporal pallor, left eye hazy medium. This is a B scan. In left eye you can see the vitreous echogenicity, right eye anechoic. MR bench showed bilateral optic neuritis, anti-MOG antibody positive and anti-aquaporin 4 antibody negative. Patient was also treated similarly. Visual acuity after 1 month was improved to 660 in right eye and CF 1 meter in left eye. Conclusion: 3 cases of optic neuritis affecting both eyes have been reported with varied presentations and visual acuity ranging from 660 to perception of light associated with abnormal pupillary reflex. Fundus findings showed pale disc in 1 case and disc edema with pallor in 2 cases. All are positive for anti-MOG immunoglobulin and negative for anti-aquaporin 4 immunoglobulins. Patients were treated with IV steroids initially, followed by oral steroid, and IV rituximab was administered in 1 patient. Visual improvement was noted in 2 of them. Discussion: Optic neuritis is a group of disc conditions that involve inflammation of the optic nerve. Patients present with partial to complete vision loss within a few days of onset and also have disc chromatopsia with pain on ocular movements at the presentation. Various etiologies can be responsible for optic neuritis. Presentation can be broadly grouped into two: atypical optic neuritis and typical optic neuritis. Typical optic neuritis follows a specific clinical pattern and usually related to demyelinating lesion. In atypical optic neuritis, it differs from this presentation and has a long list of differentials, and it includes neuromyelitis optica spectrum disease. Differential diagnosis: optic neuritis, papilledema, Leber hereditary optic neuropathy, ischemic optic neuropathy. Diagnostic procedures are anti-aquaporin P4 antibodies, anti-MOG antibodies along with normal CBC, erythrocyte sedimentation rate and CRP, and contrast enhanced MRI of brain of both orbits, contrast enhanced MRI of whole spine, OCT of peripapillary retinal nerve fiber and optic nerve head with a visual evoked potential. To determine whether optic neuritis represent as CS or related to MS, revised McDonald criteria applied. Management is based on optic neuritis treatment trial. Outcomes were IV steroid treated patients recovered faster within first 4 to 6 weeks post onset. However, at 6 months and 10 years, no statistical difference in final visual outcome. Oral steroid is conventional doses alone are contraindicated for acute optic neuritis because of higher rate of recurrence. Patient does not respond to IV steroid therapy can be treated with yearly plasma exchange, azathioprine and myclophenolmofetil for long-term immunosuppression and prevent recurrence. Rituximab, which
Please
is a
conclude.
monoclonal antibody, decrease relapse and increase stabilization of disability neuromyelitis optica spectrum. These are my references.
Thank you, Dr. Ramesh Babu. Is this a case of orbit and oculoplasty or neuroophthalmology?
Actually, it is a case of neuroophthalmology.
But you are allotted here.
Yes, sir.
Okay. Thank you.